Well, good evening, everybody. Hope you've had a good and successful day, and looking forward to this session this evening on implants. And I'm certainly looking forward to hearing from four colleagues, well, more than four colleagues, four organisations who are kindly contributing to this. Our opening speakers are from Cochlear. They are Kathleen and Louise. And I just hand straight over to you and welcome to this evening, Catherine.
Thank you very much. Happy Thanksgiving, and I hope everyone can hear me clearly. Louise and I are going to share the first session. We're both audiologists and work on Cochlear's engagement team, which means that we are involved with education for audiology professionals about criteria and referral, and also involved in responding to inquiries from potential candidates or members of the public and so on. So it's a real privilege. Thank you for inviting us to this webinar. It's really good to be here and to be talking to all of you. The first section, we've been asked to talk about NICE criteria and some case studies. An awareness of candidacy criteria is really important for many reasons, but certainly for two reasons. One of which is that access is actually pretty poor. And the other reason is that outcomes are actually pretty good. So in terms of access, okay, I can't change my slide. Ooh, sorry, we've got a glitch on not being able to move the slide.
Is that, if you click on your screen and then try, it might work, Catherine.
There we
Okay,
go.
brilliant. Thank you. Top tip. Okay, so talking about uptake, this is actually a British Academy of Audiology slide. And Chris Rain and his team in Bradford, the Yorkshire Auditory Implant Service, did a study looking at the reasons for the low cochlear uptake in adults. And they came up with really sort of 6 reasons that they felt were responsible for this low uptake. The ones that have been put in bold there are really ones that could affect all of you in your kind of role, because increasing awareness of patients and clients about cochlear implants where appropriate, and then referring on appropriate patients to local cochlear implant centres would be a major part of that. And the BAA, working with the British Cochlear Implant Group, are trying to put quite a lot of effort into raising awareness amongst referring audiologists to refer patients appropriately to their local centres. So the subject is important because there's really quite astounding low uptake perhaps, and also because the actual results that people get are really encouraging. So people who fulfill the criteria and have a cochlear implant, they tend to see really quite a large leap in their hearing performance and their speech understanding compared to what they were getting beforehand. So this study is indicating that on speech tests, people prior to implantation were getting an average of 28% stable with their hearing aids, and then afterwards with a cochlear implant and a hearing aid in the other ear, their performance on those same speech tests was jumping to 75%. And as you all know, when somebody moves from scoring around 28% up to 75%, that opens up a whole lot of opportunities and new doors to them, and able to do things that they previously would have considered very difficult or impossible. There's also knock-on effects, obviously, in terms of quality of life, reduced anxiety and depression, and also these days we're all aware of the link between hearing and cognitive decline. So very important to consider referring people who are really struggling with their hearing aids and fit into the criteria that we're going to talk about. So you're probably all also aware that in March this year, the NICE guidelines were revised. The previous time they'd been revised was 10 years ago in 2009. So I wonder if you know what the previous criteria were. Well, fortunately, because it's a webinar, I can't pick on anybody, but the previous criteria are what's shown in grey down there. So they were that people had to have their hearing thresholds at or worse than 90 dB HL at 2 and 4 kilohertz in both ears, and also that they were scoring at or below 50% on BKB sentence tests presented at 70 dBA in their best aided condition. So what you need to remember now is that 80 is the new 90. That's the take-home message in terms of criteria. So now we're looking at this yellow area which shows that the criteria say that they need to have a thresholds at or worse than 80 dBHL at 2 or more frequencies, and those frequencies are stipulated as 0.5, 1, 2, 3, and 4 kilohertz bilaterally. So the relaxation of criteria means that there'll be more potential for different audiometric configurations to fit within those criteria, and that's what those little diagrams underneath the audiogram there are indicating. So you're not just thinking about your typical flat, severe to profound loss at the bottom of the audiogram, or your steeply sloping ski slope loss, but there's more room for different configurations, and we'll look at that in the case studies shortly with Louise. So if you have clients who are within those criteria in both ears or very close to them, then you can refer them on to your local cochlear implant centre. The other change that was made to criteria this year was that the speech testing changed from being sentence testing to being word lists. And obviously that's a more difficult test because there's no context or much less context. So making that test harder made more people fail it, which makes more people eligible for criteria and so on. So the testing that's now used is the Arthur Boothroyd word lists, and once again they're presented at 70 dBA in the best aided condition for the individual, and they need to be scoring at or below 50% on the phoneme score for those tests. Now I would like to point out and reassure you that you don't actually need to do those tests in order to refer anybody. You don't need to do speech tests prior to referral, because those tests have to be done at the Cochlear Implant Centre in order to determine eligibility. If you do any speech testing yourselves, that's absolutely fine, and the Cochlear Implant Centres would love to have that information with a referral. So really you're just looking at people who are performing poorly on their speech tests, whatever those speech tests that you're doing. If it's AB word list, that's absolutely fine, but if it's other tests, that's really interesting information as well. Or you're looking at people who have self-reports of poor performance, perhaps on the telephone and particularly in background noise, or perhaps poor outcome measures as shown by any hearing aid questionnaires that you might use. So if you're finding people with thresholds within the new criteria and other self-reports of difficulty, then definitely they're the people to consider referring on. You may get questions about how young and how old and also how much. So in terms of children, I realise that most of you are probably working just with adults, but it's worth kind of knowing the whole picture as well. So for children, when is the best time to consider referral for a cochlear implant? Well, there is actually no minimum age limit. Typically these days, for children who are born profoundly deaf and picked up quite early on, they'll be referred straight away. And they're typically implanted between 10 and 12 months these days. It can be earlier if necessary, if there's other circumstances, perhaps meningitis, which could be leading to ossification of the cochlea and so on. I think the youngest one in the UK was actually 3 months. That's not typical, but it is possible because of the size of the cochlea. Children are funded on the NHS bilaterally, so they can receive 2 implants. Adults are only funded for 1. So for adults, what about is there an upper age limit? We do frequently get asked that question, and quite a lot of people I think believe that they can be too old for a cochlear implant. But likewise, there is actually no upper age limit. The oldest person in the UK to receive a cochlear implant is 99 at the time of surgery, and I think globally there was somebody who was 101 when they received their cochlear implant. So don't hold people back because of age or worry about that. Obviously, the Cochlear Implant Centre would need to be and will be looking at the big picture, so they'll be establishing medical fitness for surgery, and also that the person would be able to cope with the demands of the assessment, the surgery, and the fitting and rehab and so on. But they will be looking at the whole person when they're doing the assessment. As far as funding, you can reassure your clients that cochlear implants are fully funded on the NHS as long as people fit into those criteria and that they've had a full assessment at a cochlear implant centre and it's been recommended to them as the treatment for them. So to make a referral, what you would need to do is to make yourself familiar with where your local cochlear implant centres are to where you live. There may just be one, or there may be a few in your area. Our website, Cochlear's website, or the British Cochlear Implant Group website has really good information on these centres. So on the BCIG site, it will tell you the names of the coordinators and the surgeons, the mailing address, emails and phone numbers and so on. And you can reach out to the cochlear implant centres yourselves directly through those means, and they will be happy to discuss any questions you might have about a client before referral. So the implant centre will be interested to know any recent audiograms that you've got, any history of their audiological thresholds, information on their current hearing aids and their use of those. Ideally, cochlear implant candidates will be good hearing aid users. So all of the work that you've done in this area is really important because maintaining access to auditory information is really good for somebody going forward for assessment. Any relevant history you've got that would support your referral. Any speech testing or questionnaire data is great, but you don't need to have done speech tests in order to refer. And the question of when to refer is often a challenge, perhaps knowing when the best time to mention it is to somebody and to refer them on. So this graph really shows what happens to someone's performance over time with a worsening hearing loss. And as their hearing gets worse, their performance decreases. Back in the day, really, when I first started working with cochlear implants, we used to wait till people really hit the bottom there and sort of bounced along it a bit before we thought of referring them, and then they received that amount of benefit from their cochlear implant. Nowadays, with all the experience that we now have over time, and also with the more relaxed criteria, they tend to get referred earlier and they are doing better. So what we're really trying to encourage people to do is to think about referring and about bringing up the topic of conversation sooner, and to minimize the effects of waiting for our patients. And there is good data to support why we should do this and how we can minimize the effects of waiting, because there is correlation between the duration of the severe and profound hearing loss and their eventual outcome. There's correlation between their hearing loss and potential cognitive decline, which means we don't want to be delaying for them. And also the data is showing that the functional hearing can improve their performance outcomes. So by that I mean if they've got a little bit more hearing, we're still within those criteria, they're likely to do better than people who really are kind of at rock bottom of the audiogram. So those are all reasons to encourage us to start talking about this sooner with our patients and try to catch them when their performance is beginning to decline, rather than when it's really they're getting absolutely nothing from the hearing aids. Because the earlier we implant someone, the better they will do. And we really want to help patients think about cochlear implants as kind of the next step if their hearing is deteriorating, rather than as a kind of negative last resort. So I hope that graph is quite helpful in illustrating that. And now I'm going to hand over to my colleague Louise, who is going to take a quick look at some case studies.
Okay, I'm going to whiz through these, and I'm very aware that you're not going to answer me. But we're going to have a look now at a few audiograms. So you can see this one here, and it's from an adult. We don't know the cause of their hearing loss, but they are reporting little benefit from their hearing aids. So judging on what Kath has talked about today, would you refer this person? And the answer is that you can certainly consider referring this person. So if they are motivated to learn more about cochlear implants, they're well within criteria. And because they're reporting that they're having little benefits from hearing aids, then this could be an appropriate next step for them. So now we have another patient who has congenital profound deafness. So I think it's interesting to see here that his speech is unintelligible and undeveloped. So would you refer this person, and what for? This person's certainly still in criteria for a referral. So if they're motivated to learn more about cochlear implants, you should definitely refer them. But it is important to note that when Kath talked about performance with cochlear implants, this person might not perform as well with a cochlear implant as someone who has a postlingual or slowly declining severe to profound hearing loss. Now we have another patient here with single-sided deafness. So they're reporting that they're struggling with their cross hearing aid. So would you refer them, and what for? Now this person has normal hearing in their left ear. So that means that they're actually not in criteria for a cochlear implant. But you could definitely refer them for a BSHAA if they are struggling with their cross hearing aid. So we've got one more person to look at, and that's actually this lady, Susan. So you can see that she's got a steeply sloping hearing loss. She's tried new hearing aids with frequency lowering technology, but she still reports difficulties at work and hearing on the phone and in background noise. So would you consider referring her? You certainly can, because once again, she's got two of those thresholds below 80 dB at 2 and 4,000 Hertz. So Susan did get referred. And I wanted to highlight the importance that people can be referred when they do have a lot of residual hearing, and it is possible to preserve that residual hearing based on surgical techniques and also the electrode arrays that are used these days. So you can see that this is how Susan performed before her operation, but post, her thresholds only dropped by about 15 to 20 dB, so they were able to preserve her hearing. And in that case, she actually got a hybrid device. So a hybrid device uses a combination of the cochlear implant with an acoustic component to stimulate the low frequency. So the acoustic component attaches to the sound processor of the cochlear implant, and then you have the electrical stimulation in the high frequencies. And Susan went on to get this, and she did extremely well and performed way better with her cochlear implant. Now, I feel like this has been a whirlwind explanation of the new criteria, so I'm being mean and I'm giving you some homework. Now, I would like it if over the next week or two you could take some time out to watch this video. So this is a new video developed by BAA and BCIG, and it's just about the awareness and barriers with cochlear implants in adults. And to have a read of this article. So this article is written for referring professionals by referring professionals. So it goes into more detail about how you can counsel with your patients about cochlear implants and the common barriers that people often face. And as Kath mentioned, have a look at the BCIG website. You can learn more on there about the clinics that are local to you, and there's a lot of facts that you can learn on there, and there's also posters that you can download for your clinic. Now, if you have any questions, you can reach out to us on our website. So that's at hearmore.cochlear.com, or our email address is hearnow@cochlear.com. So if you want any more education or materials, please reach out to us. And that is our part done. Thank you.
So thank you very much for that, Catherine and Louise. What I forgot to say at the beginning was, of course, as usual, people can ask questions on the dashboard. There's a column there for questions, and we'll pick up those questions and fire them out there. I think it's probably, as there aren't any at the moment, I think it's probably best if we move on and try and collect some questions at the end, which we can perhaps use in a sort of panel with all of the speakers today. But I understand that our next speaker is from Oticon
Medical.
It is indeed. And do I have the name? Is that Shibasis, Jay?
Yes.
Okay, are you there? There you are. I see Shibasis before us. So very much welcome to Oticon Medical and your good self, Shibasis. And we look forward to what you have to share with us as part of this webinar. Thank you very much.
Thanks, David. Are you able to see my desktop?
We can see your desktop. It's on the. We've got the slide there, but it's not in. Yeah, that's it. That's fine. Perfect.
Great. Thank you. Good evening, everyone. My name is Shibashish Chaudhary. I am an audiologist and I work as a clinical research manager for Oticon Medical in the UK. So I've been asked to talk about bimodal hearing solutions. Why can't I change my? Yep. So just to before starting, I want to give a bit of a history as who we are and what we do. So we are part of the Demand family, and we are in the whole sphere of hearing healthcare services, right from hearing instruments to cochlear implants to bone-anchored hearing solutions, diagnostic instruments that most of which you're probably using on a daily basis, and other related areas like assisted listening devices. So the scope of the presentation today is to understand the contraindications of cochlear implants, understand what is bimodal hearing, and have some case studies. But what I have done is that I have gathered some literature on bimodal fitting to give you an understanding of what is bimodal hearing and what are the bimodal hearing benefits. So starting off with contraindications of cochlear implant surgery. So if there is a case where there is a significant benefit from hearing aid observed, then cochlear implant surgery is a contraindication. But it should be noted that the benefit from hearing aid may vary across regions. And as you have learned from the previous presentation, that even the benefit within the UK, the criteria has changed. Other contraindications could be chronic infections of the middle ear, mastoid cavity, and or perforated tympanic membrane. And also hearing loss due to complete cochlear ossification or lesions to the auditory nerve and beyond. But if the lesion is limited to the auditory nerve, a brainstem implant may be useful. Also, if the patient health does not allow to undergo surgery, for example, specific hematologic, pulmonary, or cardiac conditions, then this could be also considered as contraindications of CI surgery. And one of the most important thing is also patient's motivation and the family's support. And also you have to set the expectations right for cochlear implantation to be successful in the long run. I'll move on to Jay, sorry, the slides stopped advancing again.
If you click on the screen, Shivashish,
Yeah.
that might work.
Yeah, I'm trying to do the same thing. Oh, started again. Sorry about the glitch. So what I have done is I've tried to put it as what is bimodal solution and what is bimodal benefit. Then stopped again. Then I'm going to talk about when do you see bimodal benefit and why do you see a bimodal benefit and who might benefit from a bimodal solution and how could you achieve a bimodal benefit when you're fitting a hearing aid with a cochlear implant. So starting off with what is bimodal stimulation and what is bimodal benefit. So bimodal hearing is combining electrical and acoustic stimulation across 2 ears. In some studies, this might be also called as an electroacoustic stimulation, but electroacoustic stimulation is mainly referred to with a hybrid cochlear implant system where cochlear implant is used to stimulate the high frequencies and the hearing aid is used to stimulate the low frequencies within the same ear. And what is bimodal benefit is the additional benefit that is observed when you are giving an acoustical stimulation to the contralateral ear and a hearing aid to the implanted and a cochlear implant to the implanted ear. So when does bimodal benefit occur? And these are like, I'm giving some data out of published literature. So bimodal benefit mainly, the benefit mainly occurs when in speech perception in noise. As you can see in the screen, you've got the CUNY sentences. And so when there is no noise, the bimodal benefit is limited, but when there is a noise in the background, you see more benefit from a bimodal fitting. Also, the type of noise makes a difference. So if there is a male talker with a male masker, there is no difference in the F0 between the two signals. You do see a bimodal benefit, but the bimodal benefit is more prevalent when there's a male talker and a female masker. And that's because there is some F0 difference, which is better conveyed by hearing aids. I'll move on to another study, which shows that there is improved music perception, and it's mostly related to the timbre and the sound quality. There are studies that have shown that there is improved localization when you're using bimodal fitting, and it's understandable why, because you're giving some stimulation to the contralateral side. And in this slide, you could see that when there is a cochlear implant alone condition, there are root mean square error in degrees, which is the degrees by which they are away from the actual source from which the sound is coming is higher when you're using just a cochlear implant. But when you're using a cochlear implant or hearing aid, you get better localization performance. So to summarize, you get improved speech perception, especially noise, with bimodal fitting. You get an improved music perception with better timbre and sound quality. It might also help you in improved sentence intonation or suprasegmentals of speech, like stress, intonation, and rhythm, and also improved localization. Now, let's try and understand why do we see a bimodal benefit. And for that to understand, it is important to know how the cochlear implant is working. So here I have got a waveform on the left-hand side, and that is then segmented into different channels, and that's what a cochlear implant will do initially. So you can see the different amount of energy in different channels. But what a cochlear implant actually provides is just the temporal envelope cues. So most cochlear implants will just provide temporal envelope cues and what happens when you add the hearing aid on top, what happens when you're getting the hearing aid on top is that you're not only getting the envelope cues, but you're also getting the periodicity cues. And that helps in additional cues such as manner of articulation, voicing, stress, and intonation. So here is a slide that discusses about the scenario of bimodal users across countries in the Europe and also USA. And you can see the most amount of cochlear bimodal hearing aid, so bimodal users are actually found in Germany, and over in USA you see less number of bimodal users, and that is because of the fact that there are more bilateral users in the USA. So it all depends upon how cochlear implant is funded in different countries and also the awareness. So who might benefit from a bimodal solution? And the question that might come to mind is that, is there any minimum residual hearing that is needed for getting bimodal benefit? But most studies actually show that there is no minimum residual hearing that is needed for someone to achieve bimodal benefit. As you can see here, the average thresholds are vary across different frequencies, but their bimodal benefit doesn't, there's no correlation between the same. However, bimodal benefit is mostly observed, or most amount of bimodal benefit is observed when the pure tone average is better than 60 dB, and the chances of having a significant amount of bimodal benefit reduces when the pure tone average is more than 80 dB. As you can see in this slide, you've got this dark circle which represent pure tone average better than 60 dB, and the white circle where pure tone average is poorer than 60 dB, and most amount of benefit is observed when the pure tone average is better than 60 dB. So how do we now fit a cochlear implant and a hearing aid together? So what we offer is the Neuro 2 hearing is the cochlear implant, and that is matched with the Dynamo SP hearing aids. And a lot of you work in the hearing aid industry would know about the Dynamo and the Sensei SP hearing aids. So this is our bimodal offering, which has got aligned signal processing. They are wirelessly connected, and they also have good cosmetic fit. So for the bimodal system to work properly, a couple of things needs to be taken into consideration. For example, if you have a hearing aid and a cochlear implant on either side, it is important that they are making similar decisions, or they're making rational decisions. So what we do is that we have the front-end processing in the Neuro 2 sound processor, as well as the Dynamo and the Sensei SP hearing aids as same. They make the same decision while they're capturing the sound. But what we have done is that we have gone one more step further, and what you've done is that the sound coding strategy in cochlear implants and hearing aids are different, but we have tried to use this similar sort of rationale. So we have something called speech guard in our hearing aid software, which is implemented to maintain amplitude modulations, and a similar rationale is there in our cochlear implant sound coding strategy, which is called as the voice guard. So not only at the signal processing we are aligned, but we're also trying to align the sound coding strategies. So our fitting principle it depends on aligned pre-processing. We're trying to avoid distortion of sound cues and preserve quality using the Dynamo's speech guard and the Neuro's voice guard system. And finally, which is important, we're trying to ensure loudness is balanced. Now, based on our understanding of bimodal fitting, what we have done is that we have incorporated a bimodal fitting section within the hearing aid software. So if you open up Genie software, which is what you use to fit Oticon hearing aids, you'll see a section of bimodal fitting, and this section will help you or assist you in doing a bimodal fitting. So what we have done is that there are a few variables that you need to take into consideration. And one of them is, are you going with a wideband fitting or not? Are you planning to do frequency lowering? Is it going to be reduced bandwidth with or without low frequency emphasis? And finally, loudness balance. Now, these are quite a few variables that you need to keep in mind. So what we have done is that, along with the Boys Town National Research Hospital, we've come out with a flowchart. So this flowchart, it can be downloaded from the from the website. You can just go to bimodal.oticon.com, and this will give you a flowchart and guide you with your bimodal fitting. So when I was talking about acoustic bandwidth of the bimodal fitting, here's another research from Zhang et al. In 2015, which looked at how much of a bandwidth should you be amplifying. So what they found is that if there are when in cases of sloping hearing loss, you might find patients who have dead regions, and it is better to only amplify till the edge frequency of the dead region that you can find out using 10 test or PTCs. So when they've used to only amplify till the edge frequency of the band of the dead region, they found more benefit compared to the benefit getting reduced when a full bandwidth was amplified. So the take-home message from all this is that do not expect same results for all your patients, and you will tend to see more benefits in patients where the PTA is below 60 dB. There's different fitting strategy that you might need to consider based on the pure tone average or the presence or absence of dead regions. You need to preserve the natural quality of the signal, if not frequencies essentially, but if possible, provide a wideband signal. And also with regards to frequency lowering and compression, this has mixed results, so you might want to try both of them. With regards to the cochlear implant fitting, you would not need to change any frequency map, but we need to keep in mind what might happen in the future, because a lot of patients have progressive deafness, and fitting of loudness levels across frequencies need to be taken into consideration, keeping in mind the other ear. Okay. So finally, I just wanted to talk to you about what we're offering. Here is our streamer which will stream both to the cochlear implant and the hearing aid, and you can use the streamer to control both the cochlear implant and the hearing aid. It'll act as a remote control as well. And in the NHS, we have got the Dynamo and the Sense ISP hearing aids, which come in 10 different colors, and you will find a similar match with our cochlear implant Neuro 2 system as well. And thank you for your time.
Well, thanks for that, Shubhasis. Just one thing that springs to my mind as you've gone through that is at what point in the process a decision might be made that my bimodal is worth considering. Does the individual have to get used to the cochlear implant to begin, and then a consideration as to whether bimodal would be an improvement, or where in the cycle would you look at that?
This is a very good question, actually, and answer, because there was some research done on this, and what the research shows that most cochlear implant audiologists will ask the cochlear implant user to have a period of use with just the cochlear implant and not use the hearing aid, and then bring it after 3 to 6 months of their cochlear implant use after switch on. I don't know what's the best time to introduce a hearing aid is, because I've seen benefit when the hearing aid and the cochlear implant has been switched on at the same time or fitted at the same time, And in fact, we have just received RS ethics application to run such a study where we are comparing two different scenarios. Half of the patients are getting cochlear implant and hearing aid on the same day, and we call them the co-modal group because we call them as a complementary modalities. The hearing aid being a complement to the cochlear implant. And then we'll have another group which we are calling the delayed bimodal group, which will get their cochlear hearing aid 3 months after cochlear implant switch on. And you're going to test both the groups, not only for speech perception but also for music perception and listening effort. So I might have some answer to your question in few years' time, but at the moment, most cochlear implant audiologists that we have spoken to advise the hearing aid to be fitted after a gap of 3 to 6 months.
Okay, that's helpful. Stay with us, and we might get some more questions in a little while. But now it's time to move on to Jennifer from Medel, and Jennifer, we look forward to what you have to share with us too. Thank you. Your mic's not on at the moment, Jennifer.
Microphone on. Can you see my screen?
Yes, if you put that into show the screen rather than individual. So sorry, if you put PowerPoint into show.
You should be able to see the PowerPoint, can you?
We've got PowerPoint, but it's in the usual ones. We've got the slide and the future ones alongside it. So if that's fine. That's where we need to be.
Lovely, wonderful. Well, thanks everyone so far. Can you still see the screen? I can't see it. There we go. Okay, and you can all hear me. Well, thanks for this opportunity this evening. I'm going to talk to you a little bit about who Medel are and the different products that we can offer, and hopefully there'll be some kind of take-home solutions for you that you can start in your practices tomorrow. So, who are Medel? Well, we are the leading supplier. Oh, hang on. There we go. Just move this out the way so I can see. We're the leading provider of hearing implant solutions. We're in over 120 countries. We're a privately owned company. What does that actually mean? It means then that we're not answerable to shareholders. So we really have this philosophy about reinvesting the turnover that we make in research and development. This is Ingeborg and Erwin Hochmer, who own Medel, and that's our headquarters out in Innsbruck in Austria. They invented one of the first multi-channel cochlear implants back in the 70s. And have continued with pioneer products over the time. So what do we have in the portfolio range? Well, we look at providing synchrony cochlear implant system. You've heard a little bit earlier on about implant systems where you can provide cochlear implantation, but it can also provide an acoustic amplification. We also have middle ear implants, so we have the sound bridge, the bone bridge, and the adhere. What we're going to talk about today is the sound bridge system and the bone bridge system and our first non-surgical device, which is the adhere. So we can look at candidacy, we can look at some case studies that we've got, and by all means send your questions. So what are the target groups? Well, we can look at sensorineural hearing loss, mixed hearing loss, and conductive hearing loss. They're all suitable for sound bridge implantation. With bone bridge, predominantly we're looking at mixed hearing loss, conductive hearing loss, and single-sided deafness. And then finally, we can look at our non-surgical device, adhere, which some of you may already have some familiarity with. Okay, so what is the sound bridge? Well, it's a middle ear implant system, and the philosophy with Medel is that we believe in intact skin solutions. So what you can see on the screen there is the implant, which is underneath the skin, and then the audio processor, which is on the outside, which is attracted by a magnet. Surgeons like this device because it gives them a little bit of flexibility. For example, with sensorineural hearing losses, they can attach one of the couplers onto different parts of the ossicles, the short process, the long process, onto the neck of the stapes. And for people that have perhaps got radical cavity, they can put the floating mass transducer into the round window. So what happens is the audio processor collects the sound and does all the stuff that we would expect a sophisticated processor to do, and it actually tells and translates that into mechanical vibration, which then in turn stimulates the fluid in the cochlea. So how does it help? Well, it's really good for bypassing anybody that's got outer or middle ear issues. There's no need for reconstruction surgery, and it doesn't interfere with pinna reconstruction. So really good for some of these microtia patients that are out there. What are the kind of common pathologies? If you see somebody that comes into your clinic that has chronic otitis externa, for whatever reason they cannot use a conventional hearing aid, and depending on their audiogram, this would be a really nice solution for them. Again, with mixed hearing loss after middle ear surgery, because we need to get the pathology eradicated first. So again, what are those pathologies? Chronic otitis media, tympanosclerosis and cholesteatoma. And what that can do is close that airborne gap. So on the left of the screen, this is the criteria or the candidacy for a sound bridge. So really anybody that's up to about 85 dBHL. Oh, it's moved on. 85 dBHL for sensorineural hearing losses. On the right of your screen, if you've got somebody that's got conductive or mixed hearing loss, we're interested in looking at the BC values to a maximum of about 65 dBHL. So, case example. Noise-induced hearing loss, we're all familiar with this type of audiogram. It's really important that the hearing loss is stable, that they've had some kind of benefit from hearing aids. This particular case example, they've got eczema in the external auditory canal, tried conventional hearing aids, but hasn't been feasible. Oh, screen's gone again. Speech reception thresholds, tympanometry, all in keeping. What about conductive hearing loss then? What kind of devices could patients be offered instead of some of the stuff that's out there? Well, MED-EL are really proud that we have the first active bone conduction device. We're now on our second generation. And what's nice about this device, as you heard me talk about earlier, this is completely transcutaneous, so it's completely under the skin, so there's no abutment, there's no open wound. Again, safely embedded under intact skin, and infections and complication rates are expected to be within the range. So bone bridge, this is the candidacy that we're looking at here. So BC values, we're looking for 45 dBHL or better. It's also a good option for single-sided deafness. Okay, so we have another case study. This is Ross, age 55. He had a unilateral conductive hearing loss, suffered with atresia microtia. He did use a cross hearing aid system, but he decided to opt for a bone bridge because he didn't want the abutment. Another important feature of our devices, with our CI devices, that you can be scanned at 3 Tesla, and with sound bridge and bone bridge up to 1.5. And this is important as we've got this aging population and everybody's getting older. It's quite likely that we will all have at least 1, maybe 2 MRIs in our lifetime. So the final product here, and something that you could potentially use in your clinics tomorrow. So it's the ad here. Brand new concept. It's actually been around for about 18 months, and I can talk about some of the studies and the efficacy studies during this presentation. So what is it? It's essentially the adhesive adapter, which goes onto a hairless part of the mastoid, and an audio processor that clicks onto that. This just gives you a bit of a closer up. There we go. So you place that in the hairless area of the mastoid. It's a single use, so the minimum that you can, minimum time that we've got away with people wearing it has been 3 days. Some people have reported 8 or 9, but we say 3 to 7 days you can get single-use adhesive. You can take the processor off, people can go swimming in the shower. As long as you take the processor off, the adhesive will stay on. It's really comfortable, and the most important thing when we talk about bone conduction devices, it exerts absolutely no pressure onto the skin. It's biocompatible and safe for long-term use. So this is the actual processor itself. You can see the coupling mechanism. It's a really low profile, low weight design. Anybody that I saw at BAA a couple of weeks ago would have had the opportunity to have a look at that. It comes with 4 pre-configured programs. It's a linear amplification, as you would expect with a conductive device. So the 4 programs are omnidirectional, mute and direct audio input. But normal size 13 battery, and you're getting about 2 weeks out of each battery. So this just gives you a visual of the different elements onto that. You can configure the audio processor. It's not programming as we would see normally in clinics. It's configuration, so you can make alterations. You can, for example, if you just wanted to give someone one program, an omnidirectional program, you can do that with the configuration software. You can also, it's got 8 independent compression channels, but again, it's a linear amplification, so you would just tweak that over certain elements. So, candidacy, who can benefit from Adhere? Well, if we look at congenital losses, children or adults that have microtia, atresia, stenosis of the ear canal, or with acquired hearing loss where people have any kind of conductive element really, so that's damaged ossicles, otosclerosis, TM perforations, otitis externa, glue ear. It's very popular with paediatric departments for kids that suffer with that, with these transient hearing losses. And somebody that maybe that produces a lot of wax and is struggling to wear conventional hearing aids. So this is the criteria. You need to have good functioning cochlea for suitability for the Adhere, so 25 dBHL and above. Again, with single-sided, if you're looking at it from a single-sided deafness perspective, you need to have the contralateral ear really on 0 dBHL. There is no age limit, as I said before, it's a completely non-surgical device, so there is no age limit on that. So why Adhere? Well, this is the options that are available to people. I'm sure we're familiar with soft bands and Brook-off devices, and not all patients want surgery either. The problems that we have with soft band and hard band and bone conduction glasses, there's a lot of pressure onto the skin. Because of the design of Adhere with the adhesive adapter and the processor, there is no pressure without losing any output. With soft bands, again, it's unreliable placement. The transducer can move out of position. And I think the third final point is it's a self-consciousness. It's a stigmatization of wearing soft bands. So, like I say, it's a new concept. It's no pressure. It's got reliable positioning, and it's much more cosmetically appealing for people. So what have been the learnings so far? Well, there's numerous studies going on across the world, certainly here in the UK. Anna-Louise McDermott at Birmingham Children's Hospital, her study is now published, but this just gives you an idea of some of the studies that have been going on throughout the world, and we could have a look at some of those. So the topic was efficacy in experienced children, so it was Adhere versus the soft band, and the conclusion to that was that the audiological outcome was comparable. So you get about 36 dB of gain from the Adhere. Really comfortable and easy to use, no soft tissue reactions, and was very well accepted by children and their carers. Out in Warsaw, they looked at comparing Adhere versus soft band versus passive bone conduction implants. Again, add here the conclusions was considered as a good and effortless solution for patients who are either not suitable or denied a surgical solution. Over in Frankfurt, they looked at using it for people that had had ear surgery, and very good outcomes with that. Over in Antwerp, they did a study where they crossover study actually, where they looked at comparing the Auditory versus the cross hearing aid system. 70% reported partially useful or better, and interesting results from that study was that speech perception and noise actually improved. Out in Vienna, again, Auditory versus soft band. Conclusion, high patient satisfaction, word recognition scores significantly improved, no skin irritation or pain. So that gives you an idea of some of the evidence behind Auditory. So who would be the target groups? Children, anybody with a conductive hearing loss, you can use it bilaterally, people with transient hearing losses, and also those single-sided deafness. So the general conclusion is performing well. It's comparable to state-of-the-art bone conduction hearing devices that are out there. Very importantly, the user satisfaction is excellent, and that was mainly down to comfort and the fact that they felt less conspicuous with it. Okay, so if you would like to have a look at further materials, we have a blog on MED-EL Pro, and on YouTube there's lots of videos. Just type in MED-EL, add here, and there's a lot of stuff on there. Okay, thank you for your time. If you've got any further information, you can get in touch with me at the email address there below. Any questions?
Thank you, Jennifer. I've got Kevin Jeffries indicated that he's got a couple of questions, but he hasn't said what they are. So, Kevin, if you're there, I'm going to unmute your mic so that you can ask those questions. Hit the wrong button, he says. Okay.
We've all been having that. Yeah.
Right. In which case, let's carry on. Thank you, Jennifer. And we hand over to our fourth presenter, Nicole, and then we perhaps, hopefully, will be able to rustle up some questions for a sort of a bit of a panel conversation at the end. But Nicole, over to you. Thank you.
Well, hello, and good evening. And firstly, I just have to say, I'm so impressed with everyone that has stayed on this long on a Thursday evening. You are the true pure of heart of the profession. So hopefully what I can talk to you about today, some exciting things that maybe you haven't seen before, and that you'd find really interesting and really helpful to implement into practice. Now, firstly, just to introduce myself, so my name is Nicole de Rocha. I work for the company called Advanced Bionics, and I am one of these weird South Africans that is a speech-language pathologist as well as a clinical audiologist. I specialized in complex needs pediatrics, and I also specialized in doing medico-legal audiological work. To introduce my team, so this is the Advanced Bionics business development team. So up at the top, you see Kezia, who's our sales manager, and at the bottom, you have from left to right, Shahad, myself, and Yvonne. And who Advanced Bionics is we are a cochlear implant company, but we are under the umbrella of the Sonova Group. Now, within Advanced Bionics, we have a clinical specialist team as well as a business development team. So the team you're seeing here is the business development team, of which I'm part of. And our main goal is to increase awareness about cochlear implants to audiologists, to GPs, to pediatricians, to those in healthcare, to those in education. We also try to create events and think creatively to involve families and patients directly with our company. And also we try to think of creatively creating solutions like holistic healthcare that walks with the patient through the journey of getting a hearing loss and then seeking interventions to treat that hearing loss. Okay, so what do we mean by holistic hearing care? And the way I like to describe it to patients and to parents is, imagine treating a hearing loss is like baking a cake. Now, the cochlear implant, the hearing aid, the features of those hearing aids or the features of the cochlear implant, the accessories that go with it are like the recipe to a good cake. So things like frequency lowering features or clear voice or, Bluetooth streamers, those are like measuring the right amount of mils of milk and the right amount of eggs to get a really good cake batter. And I think as professionals, as well as, manufacturers, we are guilty of focusing maybe a little bit too much on the cake batter and forgetting to talk about what happens after you get those accessories. Because after you get those accessories and hearing aids and cochlear implants, you need to wear them. So you need to put this cake batter into the oven in order to get the cake to rise. And that is what oral rehabilitation is for. And from Advanced Bionics perspective, this is really, really imperative, because we know it doesn't matter how advanced a processor we make or how advanced our implants are. If the patients or our families are not going to wear it or not going to put the work in to acclimatize to the sound, they're going to end up with just cake batter and not a very good tasting cake. So invested are we in the ovens of the world that we have created different oral habilitative resources. So the next couple of slides, I'm going to talk to you about the background, the science on how we created these oral rehabilitative resources. So this slide is showing you the current models of auditory processing. And there are various models of auditory processing, but most of them have their origins in Erber's model of the auditory processing and auditory processing development of sound. And it starts off with detection. So when you have a hearing loss and you get a hearing aid or a cochlear implant, the first thing that the brain needs to learn how to do is to detect that sound is present or sound is absent. Only once you're able to get that done would you be able to develop discrimination. So discrimination is things like hearing the difference between it's a male voice or it's a female voice. Also things like that's a fast tempo, that's a slow tempo. Once discrimination has been established, only then can identification be established. So that is hearing the difference between plain and pan. And only once that has been established can then comprehension be established, and that is associating meaning with plain and pan. So for many, many years, therapeutically, we have been implementing this model into oral habilitative and oral rehabilitative tools. But what I found really fascinating is this study that's just come out by Felix et al. And what it was showing was anatomically the structure of the cranial nerve 8. So this is the auditory nerve. And anatomically, fascinatingly, the nerve is also structured in this hierarchy. So you have the hair cell, which is imperative for phase locking, imperative for detection. The next most important is the cochlear nucleus, really important for gap detection, spectral integration, which is required for discrimination. Then the next phase will be the superior alveolar complex, which is really important for spatial integration, spatial processing and noise filtering, which is important for identification. And then further on, inferior colliculus and the thalamus and the auditory cortex, of course, that assists us with auditory comprehension. So I thought that was super interesting, because for all these years I've been implementing this model, and we all therapeutically have been implementing this model, and now science is proving actually the auditory nerve is also hierarchically structured within this model of care. Right. The next thing to think about when you think about doing oral habilitation is that you need to think about creating resources or creating a therapeutic plan within a person-centered approach. And person-centered approaches have been shown to be evidence-based, the best therapeutic way in order to implement best practice. So what does it mean, person-centered approach? Sometimes when I go to clinics and I ask, Do you provide person-centered care? They say, yes, of course. We have a lovely waiting room with coffee and special magazines. No, that's not person-centered care. Person-centered care means that your patients are actively involved in the decision of their therapeutic intervention, as well as actively involved in their actual habilitation or therapeutic tools. So when we create resources, we think we need to create resources that can fit into this person-centered care approach. And then the last thing to think about when you think about oral habilitation is what type of stimulus are we going to use to orally habilitate? Now, I love this quote, the quote by Carol Flexer, who is a prolific early interventionist. And it is true that the ears are just doorways to the brain. So what I've done here is I've taken a screenshot of an fMRI of the brain, and it's the brain's reaction to different auditory stimuluses. So the first little brain image that you're seeing on the top left-hand corner is our brain's at resting state. And the hotter the color, the red color, is showing activity. So it's showing blood flow, consumption of oxygen within the brain, which means activity. So if we look at the one just below that, the brain's reaction to language, you see the brain start lighting up. And as a speech therapist, I get really excited because I look at the corner there and I look at Broca's area, which is the little area you're seeing in the middle of the brain light up. It's really important for speech language processing. But if you look just to the right-hand bottom corner, you see the brain on music. Now that's really fascinating. Music is a really interesting stimulus to use to activate the brain, because what you're seeing here is the midbrain being activated, as well as the frontal lobes and Broca's area and the occipital lobes. So music is a very unique auditory stimulus because it taps into parts of the brain that language doesn't. It taps into that midbrain as well as the limbic system part of the brain. Limbic system part of the brain is the part of the brain that holds the amygdala, the hippocampus, so the parts of the brain that work with emotional processing as well as emotional memories. And that's very, very interesting because this is a uniquely human thing. So of all the animal species of the world, human beings are the only species that associate music with emotion. So therapeutically, that's really significant for you guys to know, because using music as an oral habilitative tool taps into various parts of the brain. And when you combine music and language, as in the top right hand, so towards the right hand side, the middle part, that last image, language and music, you see that it's giving you a whole brain workout. It's like a Christmas tree, the whole brain has lit up. Okay, so knowing all of these things, Advanced Bionics has created resources that hold true to those models of care. So it holds true to Urba's scientific model of care. It thinks about using music as an oral habilitative tool, and it also thinks about creating resources that are easily accessible and that you can implement in a person-centered care approach. So ta-da! Welcome. This is now the new rehab portal. So before, we had these resources, but they were spread out along our web page, and there was different passwords and logins to get in there. So what we launched this year is we collated all of our rehabilitative tools into one page, and you'll get there by typing in AB Rehab Portal into your web browser, and you'll register as a professional. And this will then give you access to the oral habilitative tools all in one site. You only need one password. So before, we had voucher codes that were required for certain of the tools. No more voucher codes are required. We've made things truly open and accessible. And such is the commitment of Advanced Bionics that we truly believe in the ovens of the world, that we have made this open source. So it doesn't matter what brand of hearing aid your patient is wearing, or even if they are wearing hearing aids at all. The same with cochlear implants. Doesn't matter what brand of cochlear implants. We've opened up these resources to all because we realize how important oral rehabilitation is in our patient's journey. So what I'm going to attempt to do now is to go live onto the portal page. So please do let me know, David and Jay, if this messes up the screen. So hopefully you can still see my screen. Just going to minimize this one and show you the portal page live. So hopefully what you're seeing here is the AB Rehab portal live. And when you register as a professional, you get this little icon here on the screen that shows you the user type. So you can toggle between different pages because there are certain resources that are more relevant for pediatrics and certain resources more relevant for adults. But as professionals, you want to see all of them, and then there are resources that are relevant just for professionals. So here you see the different rehabilitative tools. So you've got Baby Beats, Sound Success, Listening Room, Musical Atmospheres. Those are our 4 most important rehabilitative tools that we have developed. And then the rest of the portal page is just chock-a-block full of counseling tools like Hearing Journey, there's parent journals in there, there's tools for schools, there's the STEPS program names, those are assessment tools, there's teen web pages, there's our YouTube channel, there's webinars for parents as well as professionals, and then there's loads of information about our accessories and connections. And then right at the bottom, we've also got a whole range of apps that we have found very beneficial to use for oral rehabilitation. So what I'm going to just quickly talk to you about is the tools that I think you guys in practice will find most useful. So I think majority of you in private practice and majority of you are seeing adults. So I'm going to speak specifically about Sound Success and about Musical Atmospheres and the Listening Room. Baby Beats is our early intervention resource. So it's the resource that we use in the age range 0 to 5, and it uses music to create listening skills and communication skills, language, as well as socio-emotional development and parental bonding. So let's start with Sound Success first. So Sound Success, when you log on, this is the page, when you follow the link, this is the page that you see. And the first thing is to make sure you select the right language. So select UK English if you're seeing UK patients, because accents do play a role when you do oral rehabilitation. And you see there's 2 little phases here. There's getting started and up and running. So getting started, if we open up getting started, slow and steady, there we go, good internet. You start with listening to paragraphs, and if you think about the URBA's model, detection, discrimination, identification, such is this rehabilitative tool structured. So it starts off with listening to paragraphs, and as you go down, it works more on discrimination tasks and then identification tasks. So the first phase is to choose a topic. So for example, shopping. And what you have here is written text, and you have video, and you have audition. So you won't be able to hear Margaret speaking here, but I'm just showing you the demo of how it works. So you've got the written text, you've got the video, and you've got the audition. And it depends on what your patients are working on. So if they're working on just detection, the point of this is just to see if they can get the main context of what's being said using the written text as well as the lip reading skills. If you want to challenge them a bit further, you switch the video off. So you can toggle the video off, and then you can see, can they still follow what's being heard if they just hear it without lip reading and follow the written text. And then if you want to challenge them even further, if you want to work on identification tasks and discrimination tasks, you can add noise. So you can add, firstly, traffic noise, which is easier to identify against, and then you've got babble, so soft talking, medium talking, loud talking, which is more difficult to discriminate and identify against. If you'd like to use this tool just to improve lip reading, you can. So here where it says change speaker, there are different speakers, and it's organized in a hierarchy. So it starts off with Margaret. Margaret is the easiest to lip read, and it ends off with Vic, who is the most difficult to lip read because he's got an accent and a beard. So incidentally, you can use Sound Success as a lip reading program as well, which is quite useful. So that's Sound Success. Now I want to show you musical atmospheres. So remember, my earlier slides were talking about using music as an oral habilitative resource and how good that is. So that's where musical atmospheres came from. And it's also based on the science of URBA's model, starting off with identification and going upwards to comprehension. But it's using music as an auditory stimulus tool. So it starts off with musical atmospheres, the green little icon here, and as you go across, becomes more and more difficult. So level one is just playing the different musical tracks and listening and to what the feeling that musical track is giving you. So for example, the track 1 is the theme song to Pink Panther. So you would hear dun 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 dun, you think, suspense, detective. So that's very interesting because it's tapping into that auditory memory part of the brain. And also it's a great tool to use in adult groups to get them talking to each other, and why do they get that feeling with music, and why do maybe other cultures and other diversities get another feeling with music. So if you were ever to run a group, this would be a great tool to use to run in groups, and it's also really fun to use as well. Then we've got listening room. Now, the listening room has been around for quite some time. It was designed by Dave Sindri, who is AVT. He's quite a well-known person in the AVT world. So the resource is predominantly using listening and spoken language. But I don't think that we speak about it often for adults. And definitely you can use listening room for adults. So when you register, the listening room, when you go through the rehab portal, it's going to ask you to log in a second time. And the reason it asks you for a second login is because this resource, this tool, is truly a telehealth, teleaudiology type of tool. You've got the, you can send exercises. So you've got the little tab here that says My Clients, which means that you can add patients and you can send activities to your patients remotely, and patients can send you feedback remotely. So that's why the double login for GDPR purposes. So the lessons, if you filter the lessons and you go down, you'll see in this filtering tool that you can filter by age group. So for you guys, predominantly you'll be using the adult resources here, and loads of activities. So listening room, there's over 6,000 activities, worksheets, workbooks, and all within that premise of working on discrimination identification. Telephone practices on there, as well as some counseling tools on there as well. So those are the 3 predominant tools I wanted to speak to you about. There are other resources here like Hearing Journey, which I've opened up here. Now, Hearing Journey, what it is, it's the world's largest online blog. There's over 37,000 members on Hearing Journey. And it's an online blog for those that have hearing loss, those that have cochlear implants, those that are thinking about getting cochlear implants. Everyone can join the Hearing Journey. And I really like the Hearing Journey as a professional, because sometimes we get asked these random questions as clinicians. Like the other day I was asked, what's the best bike helmet for my child with cochlear implants? And I thought, gosh, I don't know. So I posted on Hearing Journey, and then I got a number of responses within the next couple of minutes. So this is a really great tool to use to, connect, ask questions. The other thing is that we have mentors. So in the UK, we have 53 mentors that have cochlear implants that have volunteered their services to speak to other people that are going through the decision whether to get a cochlear implant or not. Also, we have parent mentors on there as well. So if you browse our mentors, this is another non-threatening way. If your patients are thinking about getting a cochlear implant, the feedback that we got was that they want to speak to someone else that has gone through the journey. So this is a non-threatening way for them to connect with someone who has gone through the journey, or a parent that has gone through the journey, and for them to make those connections as well. The other tool is Hearing Like Me, which is our newest blog, where we put lots of different commentary about the Hearing Like Me is a place where we can share different things in the news about, apps that help for people to hear music, celebrities, technology. We've got a community spotlight and Ask Anna to ask any questions. Again, it's not just for people with cochlear implants, it's for anyone that has hearing loss or hearing aids. And it's a really great tool to just browse and use and to connect with the news of the world and what's happening in the deaf community around the world. So quickly, just to go back to my presentation, I've given you just a taster, really, of the rehabilitative tools that are available. If any of these interests you, or you want to find out more information, please do contact us. This presentation, the rest of the presentation goes through those different tools in a bit more detail, but we don't have time for that tonight. But what I can just encourage you is that there is lots of research behind using online auditory rehabilitation tools. We know that online rehabilitation tools improves quality of life. And we also know that phoneme discrimination training improves speech perception for those that are not yet using amplification. So if you're seeing patients that are not yet ready for hearing aids, then at least you can give them this oral rehabilitation tools as a resource to help improve their speech discrimination tasks. So there's loads of research behind us. And I think I'd just like to conclude by saying, let's get baking. And here's my email address at the bottom. If you'd like to find out more information, or you'd like us to come in and give you further detail or the science behind some of these rehabilitative tools, do email me and we'll get together. Thank you. I'm going to hand over back to you, Jay.
Thanks, Nicole. Thank you for that. Now then, we still no questions out there, except that as chair, I always have a question, as many of the audience will know. And I'm particularly struck by almost the cycle that we've gone through here, that in our towards the beginning of our evening, it was made clear that one of the criteria for eligibility is the psychological attitude, the family support, that willingness to be able to benefit from an implant of whatever variety. And we all know, and we've heard so enthusiastically from Nicole about the importance of that psychological engagement. And I'm just wondering if I can ask all four of you if you're aware of any preparatory work that will stop people getting rejected simply because they're not ready. Is there any particular tool or any particular piece of engagement or family preparation that makes sure that people who might be on the borderline of being rejected because they're not, their attitude and readiness for adoption is not right? Is there anything that can be done to break that gap there and make sure that people are genuinely prepared for the consequences and to take maximum advantage? Wonder if I can fire that one at Catherine or Louise first. Gonna have to switch you on, of course. Let me just put the mics on for the. I can't do that. I'm not allowed. There's.
Hello, can you hear us?
Yeah.
Hello. Yeah, I think that's a really interesting point that you brought up. And Nicole did mention volunteers. So at Cochlear, we also have over 50 volunteers that people can connect with, so that if there are some barriers for them wanting to progress with surgery, or if they're not too sure about how they may go with their outcomes, then to be able to talk to someone who has been through that often really helps with that motivation. There's a lot of support groups out there as well for people who have different types of hearing loss. So you can have a look at the BCIG website for different support groups, and also there's things to do with microtia and atresia as well. The other thing is obviously counselling people with realistic expectations. And it's really important to reinforce to someone that if you are referring them for an assessment, it doesn't mean that you're going to get an implant. You're referring them for an assessment to meet the experts and find out if you might do better with an implant than you do with your hearing aid. And you can decline, that patient can decline to have an implant if they're not ready, but it is best to talk to the experts about it.
Okay. Did you have any comments to make on that, Shibashis?
Can you hear me?
Yes. Yes.
Yeah, I concur with what has been spoken actually. Similar to that, we have patient advocacy group as well who can meet with prospective CI candidates and speak to them about their journey. Because no matter what we say, is that neither of us have had the listening experience through a cochlear implant, and someone who has been through the journey and is able to actually explain how the process is actually from a patient's point of view, and that really helps, because I personally have had experiences when people were borderline, but having spoken to another person who has been on the journey, have then made up their mind, and also it kind of motivated them to do well.
Jennifer, I can't unmute you. Did you want to comment on that, Jennifer?
Yeah, really just to echo what other people have said, I think there's a lot of support groups out there. We certainly have peer mentors, because it's very powerful when you speak to somebody, if you're contemplating this, to discuss that with somebody that's really gone through the journey. We as manufacturers can talk technically, scientifically about things. This is about the emotion behind it. And again, just to echo what Nicole had said, I think rehabilitation and motivation are as important as the implantation itself,
Yeah, I'm just wondering again, it's to ask the question from a perspective of one of the audiologists on this webinar. How can they find it's the most likely thing is that our members would want to be able to signpost where that they're not going to be the ones providing that support and linking them into the groups. So where should they look to find those support groups?
So David, if I can comment, can you hear me?
Sure, yes.
I think most importantly is to connect with charities. So NDCS is a great charity, the Ear Foundation. So to look at the charities that are wherever you are in practice, to look at what charities are around you. And us as manufacturers do work with the charities. So that's the first place to start, because the charities do host many meetings. And then the second place is Facebook. So like our mentors have numerous Facebook groups. So it's just to make that connection with, and usually the mentors host Facebook groups, and from those Facebook groups, like our mentors host socials. And those socials are unbranded, so everyone is welcome, no matter what brand you have. The socials that our mentors host and run, and some are great, and I think that's important. That's important to feel part of the community in a system-based approach, from a mentor, from the charities, from the audiologists, from their GPs, to try and involve as much of the community as possible, to talk to them about their journey. That's I think the key.
Just want to bring Kevin in now. I've switched your microphone on, Kevin, because you've got a couple of questions which relate. Looks to me like those questions both relate specifically to the conversation we're just having. So do you want to ask them directly? You there, Kevin? I will ask. Oh, is that not Kevin? Yeah, sorry. So I've got a question here. Let me ask it anyway. I've referred a few clients for cochlear implants, and got one who thinks a great candidate, but he has reservations, and he's asking where any videos or literature to point towards. I'm guessing we've kind of covered that, unless anybody wants to add anything specifically afresh.
I think we probably all also have YouTube channels and so on, and videos on our website of user stories and that kind of thing. In this, but we are happy to both connect people to volunteers and also to meet with individuals individually if that's appropriate, and certainly to get into good old email to and fro's, answering any questions and that sort of thing. I know we're probably not unique in that, but there's definitely people like us available for any of these people, you're very welcome to put them in touch with us.
Okay, let me ask, and Kevin's responded to say that he doesn't have a microphone on, so I'm going to ask his second question here. If seeing a client with a cochlear implant already, and they wish to have bimodal fitting, I guess this is probably directed better to Shubhasis at this point. Are there any factors they need to consider about fitting a hearing aid? Potentially, it might not be a synchronized device, as unlike the way you told the story, Shubhasis.
Yeah, I mean, one of the main things to take into consideration, if the front end front end synchronization is not possible, at least make sure that the hearing aid is fitted as a complementary device to the cochlear implant. Many times while doing testings with localization, I've seen that, especially in the low frequencies, the hearing aid being aided so much that even the cochlear implant is not, the loudness, the focus is more on the hearing aid. The hearing aid is getting more loudness in the low frequencies than the cochlear implant. So a good fitting is what is very essential, even if we are not able to, able to manage the front end processing and get the synchrony. But having said that, there is some or other solution which will be similar to what the patient is wearing, or whichever manufacturer's implant the patient is wearing. And one of the tools that they can use is the flowchart that has been developed at Boystown National Hearing Research Hospital. They can use that tool, and that can be used with any manufacturer. It doesn't have to be Oticon specifically. So there is a flowchart that you can follow step by step, which will actually assist you in your journey of fitting the hearing aid in the non-implanted side.
Specifically, Kevin saying, do we use frequency lowering, etc.? Is there anything specific you need to do for the hearing aid
yes.
programming?
If you see Zhang et al. Study from 2015, it does say that whether you do frequency lowering, whether it's going to be beneficial or not, it is something that you might want to put in two different programs and check, and go with the one that the patient likes. But if you think that there is some amount of cochlear dead regions, then it's probably better to find out the edge frequency of the cochlear dead region and limit your amplification till the edge frequency. But with the frequency lowering, frequency transposition, and all those things, the literature is not very clear as to whether a person will like it or not. So it's better to give it a try, and you can put it in two different programs and see whichever the patient likes the most.
Any others want to add in there?
Yeah, sorry, just specifically from Advanced Bionics perspective, we are linked with Sonova. So I think the first place to start, if your patient has a cochlear implant, is to look at what brand of cochlear implant that is. So if they are an Advanced Bionics cochlear implant, we have specific hearing aid that works with our cochlear implant. And it's because we are part of the umbrella Sonova group. So our specific hearing aid is the NAIDA Link. To fit the NAIDA Link, it's exactly the same way as you would use the normal NAIDA from the Phonak range. There is a code that you need in order to put that into target. And then what that does, instead of using null or DSL, you use the fitting formula called Optima. And that's to ensure what Shubhas is saying, that the temporal timing, what's reaching the ear, is reaching the ear in the same way. But that is something unique to Advanced Bionics. I think my colleagues at Cochlear and Medal and Oticon have solutions for hearing aids to work with their cochlear implants. So I think for this question, it is important to know what brand of cochlear implant is on the implanted side, and then to seek assistance from the actual manufacturer of that brand of what is best to fit the under.
Conscious about time here, Nicole, and I want to give this isn't a sales pitch, so I want to give Catherine and Jennifer the same opportunity to respond. Catherine, do you want to add from a cochlear point of view?
Yes, and we're in the same situation. So we have a smart hearing alliance with GN Resound. So if you see a cochlear implant or a cochlear BSHAA device, then the best solution would be for that person to have the Lynx or Enzo or Quattro hearing aid. They can be connected in the software for the cochlear implant, and that means that then they can stream directly from their iPhone to both ears, so their music, their phone calls, and the wireless devices will also stream to both ears.
Great. Jennifer?
Yeah, unlike my friends and colleagues on here, we're not working with another hearing aid manufacturer, so many cochlear implants you can use with any hearing aid.
Okay, great. Now I've got one more question that looks a really hot off the press question, so I'm going to ask that before we close down. It's from Gaileen Murray, and she's seen a lady today in her 80s who is not internet savvy, would absolutely benefit spotting the criteria. She's struggling with speech discrimination, but she's reluctant to explore due to her age. How can the audiologist in question best put her in touch with or persuade, or any suggestions as to how to take that forwards? Bear in mind, she's not internet savvy, so all these fantastic tools we've been talking about are not the answer. Anyone want to jump in and take that one?
Yeah, I think what I'd say is we obviously need, and are quite happy not to use email once in a while. We would need to know where somebody like that lived, and to look at whether we had any volunteers who were close by who could meet for coffee, or any user groups and charities that are close by to her area, and try and put her in touch with those, and meet in person. I think you've got to do the in-person, either yourselves or a volunteer, to help her move forward and have the confidence to know that it's worth considering, and so that she would fully understand kind of what it's going to demand of her in terms of time and effort to find out, but to encourage her, because obviously it's incredibly isolating being elderly in that situation. So not to discount that in terms of too much effort, but I think she would need to have some kind of real stories and real support to encourage her to move forward.
So perhaps if I could just step in there, maybe maybe putting that in context, if the audiologist was to make that first inquiry, and potentially might be a good way forwards to meet in the to get that volunteer or whatever to meet the patient in the audiologist clinic as to broker that conversation, perhaps. Does that make sense, Catherine?
Yeah, absolutely.
And obviously, if you want resources to have in your clinic about implants, or if you need us to post something out to someone, we can definitely do that as well.
Okay, I'm running out of my permission here. 3 minutes overdue. But one other comment from anyone else there? That obviously not the same answer, but anything else?
Yeah, I have some personal experience on this. My wife is a hearing aid audiologist in the private industry, and she has had some patients where she understood that the hearing aids are no longer benefiting them, and all she did is that write a referral letter with all the audiograms and all the information in it, seeking the the patient's permission first, and referred them to the local cochlear implant center. And the patient was one of the patients who would not go into the website to find information because they were not that technology savvy. And the patient has been implanted and is benefiting from our implant. So sometimes just a plain old pen and paper referral letter helps.
Sure, I just conscious looking where I live, looking on the map of where the centres are. That might be easy if you're in a big centre like London or Nottingham or wherever else, but there are big parts of the country where it's a long old journey to make if you're not careful.
So David, I'll just add one small comment to the last question. I think one of the things that everybody has to realize is that when people go for the assessment for cochlear implant, they are not going to be implanted straight away. It's called assessment for a reason. And as long as we can counsel the parents, if it's a child, and the adults, that what you're going for is an assessment, and the decision making will happen once the cochlear implant team is satisfied that they've given you all the information. So the appointment and referral to the cochlear implant centers is mainly to get all the information from the patient's perspective, what they will get out of it, and how they will be able to cope with it. And after that, they always have a decision making capacity where they can say no. So it's not that if you refer somebody, they will definitely get the surgery done. And I think if we can counsel the patients or the parents to that effect, that changes the dynamics of how they look at the referral in itself and how they want to obtain the information.
Sure, that's really helpful. But put also in the context that for some people they live an awful long way away from. It's a big step even to go for that referral, it seems to me, and a conversation with someone who's gone through that experience might actually make it more worthwhile to decide to take that journey or not.
Yeah, absolutely. And I know that we're running late, so I'll just add one last point, that all of us in the private sector has to remember that the implant services are nationally funded. So you can just completely bypass the local pathway. So you don't have to go back and forth with the GP and everybody else, the other professionals who are involved. And moreover, the implant centers actually like the audiologists who will send the referral to them. So it's a good relation building exercise as well at the same time. So I think, as Catherine showed the data, that we are highly under-referred in the cochlear implant centers at the moment. It's not fair to the patients. It's not fair to the implant centers, and it's not fair to all these wonderful companies who are doing the wonderful research in this area. So I think all of us have to be on ball with it and just get on with it, really.
Well said, Jay. Thank very much the speaker this evening for giving up your time. We've had a good session together. I'm sure members on the call, the fact that so many have stayed on, even though I'm running late, is great news, and look forward to following what Jay just said, that there are many people who would benefit who are perhaps not being given the chance or not being pointed in the right direction at the moment. So please do give this all of your thought and effort. Do we have anything to say about the next webinar, which obviously will be next year now, Jay, or do we leave that for the time being?
Well, we will have Doug back again in February, the last Thursday of February. But we are also hoping to organize something in end of January around tinnitus. So watch this space. The BSHAA members will get the information, and the non-members will be able to see the information on social media. So we will publish the dates and the titles, etc. soon.
So thank you to Jay for organising, and thanks everybody for taking the time. And have a good rest of the evening, and we'll see you in the new year. Bye.
Bye. Bye. Thank you. Bye.
Happy holiday.
Thanks, everyone. It was really fantastic. Thank you.
Thank you. Bye-bye.
Bye.
Bye.